My name's Anne Roche, and I know many of you in this room here, but it's my great pleasure to welcome you all here to NCETA's Older People in Alcohol and Drug Conference, the first of its type that we understand that's been held in Australia. Just a couple of introductory and welcome comments, and then we'll move into the first presentation. So I'd like to acknowledge that we're meeting here today on the Kaurna land, the Indigenous traditional owners of the land here today, and we have an Indigenous welcome organised, but that might come a little bit later, perhaps. But it's my great pleasure to say welcome to this conference. When I look across this room, that it's really important for me to acknowledge and indicate that this group is comprised of quite senior and key people in both the alcohol and drug sector, the community services sector, and the aged care sector. And time permitting, I want you to do a little exercise at the end of my presentation to make sure that you get to actually know some of the people operating in these different sectors. That's part of our goal and our purpose today, is start to build networks and bridges and improve collaboration across our different sectors. Having said that, I'm also aware that we tend to speak slightly different languages, and I put a note to myself on my slides, acronyms, be aware. In the alcohol and drug field, we specialise in acronyms. And so in putting these slides together, I thought I'd been fairly diligent and conscientious about not having too many acronyms in there. As I was going through them, I thought, oh no, it's still written in code. So if some of what we start to speak about is written in this kind of secret acronym language of the AOD sector and you're not from the sector, then please put your hand up and let us know immediately. I think the other thing to recognise and to indicate in terms of our welcome for you here today is that we've got representation from every state and jurisdiction in Australia, and also hopefully we've got our New Zealand representative here as well. So a tremendous representation from quite important areas that we work in, and we see this as being a landmark day where we can actually start to identify some of the not so new but more definitively emerging trends and patterns that are occurring in relation to older people and alcohol and drugs, and move towards some specific actions and practical strategies to address what we see as being very substantial issues that will be confronting the service delivery sector. So we really want this to be much more than just a talk fest throughout the day, but to have very much a strong practical orientation and outcome as we weave our way towards the end. We've done a number of things to help facilitate that. We've provided some resource lists in your packages. We'll give you some indications of some practical activities that are underway, and that we'll talk to you also about the community of practice, the network that we've been building up and establishing over recent months as well. And we would welcome input from you in terms of what other kinds of practical, strategically focused activities that we might engage in, either in our individual sectors or collaboratively, and in terms of cross-sectoral collaboration. There are a couple of other key people that are in the audience today. I'd like to welcome all of our speakers. We've got a terrific lineup of speakers, a very strong representation from Flinders University, but a number of interstate speakers, some of whom will be very well known to you depending on what sector you actually work in. And so this is an interesting audience because of its diverse cross-sectoral nature. So a very warm welcome to all of you this morning. So now, in the interests of time, which I think we should manage reasonably well as we go through, I'll get underway with the first presentation, which is intended to paint a kind of broad overview of some of the emerging issues as we see them in the alcohol and drug, from the alcohol and drug field's perspective, and identify some of the key research, the key epidemiological data, and hopefully lead us towards some indications of where we might be able to move to into the future. Following that, the series of speakers throughout the day, and I'm hoping my voice holds, it's a bit croaky, the series of speakers throughout the day that will then drill into, in much more specific details, some of the key areas and key aspects of major interest to us as we look at the whole question about alcohol and drugs and older people. And I would emphasise that some of these are the national and international experts in their areas. So welcome, and we'll move on to this first presentation. So far I've acknowledge some of our local and national and international participants who are working with us today, throughout the day. But before I start, I'd also like to acknowledge and express appreciation and thanks to the NCETA team that's been involved with organising the conference that we've relied on tremendously, and particularly Roger Nicholas for his excellent work in the area, Alan Trifanoff, Stacey Appleton and Tanya Stenson, who many of you would have met coming through the room. Much of what we'll be presenting in both the hard copy materials and in this presentation and our full program of work that we'll be rolling out in coming months also reflects the work of both Roger and myself, but particularly our RA team, including Dr. Alice McKenty, Victoria Kostadinov and Jane Fisher. So just being a little bit clearer then about what our intention is in today's meeting, that we, as I already flagged, we're wanting to very much paint the picture for you in terms of the identification of emerging patterns and trends. So we'll be presenting some of that key data. And we've also been looking at whether there's statistically significant relationships between some of these trends. So this is the first time I've seen this done so far. So that's a helpful thing for us to get a sense of, are these just vague movements that we're seeing, or is there something of real substance here? We also want to look to some extent about causal and contributory factors, and various speakers throughout the day will be picking these issues up. We want to look at the current and projected impact on the response by services, hugely important to all of us here in the room. And as I said earlier, we want this not to just be a talk fest, but to have very strong practical implications and strategic directions to emerge at the end of the day. And we want to be able to identify some of the mechanisms by which we can address some of these emergent issues and needs, and we want to enhance intersectoral collaboration, information sharing and network building. So that's our goal for both today and our activities that flow from this. But look, as we know, the issue and concern around alcohol and drugs in older people is not completely new. People have been writing about this for the last 1 to 2 and even 3 decades, flagging it. But I think there's a greater imperative now than we've ever seen previously before. And that's for a number of different reasons. We now have better data that's available to us about older people and the use of psychoactive drugs. We've got better information about potential adverse events and effects from the use of those drugs. And we've got an opportunity now to look and plan into the future in terms of what kind of preventive and what kind of response strategies are appropriate to us. In prefacing this presentation, I think it's also important to talk about the different perspectives in the politics of ageing, that it's very easy for us to take, those of us who work in the health sector, a particularly problematised and pathologised view about these issues. But it is quite important for us to underscore the fact that when we look at ageing, we're wanting to do so from the perspective of health and well-being. We want to look at things that are actually going to facilitate the well-being of older people and not see ageing as this inevitable degenerative process, but also look at restorative health focuses. And emerging research is indicating that in people in their older years, in 70s and 80s, who do become ill or have problems that emerge, it is not necessarily an inevitable downward path, as we may often have seen in the past. So we also have a bit of a propensity for stigmatising issues in relation to alcohol and drugs. So keeping these issues uppermost in mind as we go through the presentations today, I'm quite conscious of things to try and counterbalance that. Having said that, when I got to the end of my own presentation, I thought, well, I think I've problematised this extremely well. So. I think the other issue for us is that the face of ageing is changing tremendously. So as we look across our own community, both nationally and internationally, that we recognise the incredibly active and huge role and contribution played by people who are significantly older than may have been the case in previous generations. And I'd put up that photo of Betty Churcher before she actually passed away yesterday, but I was quite pleased to have the opportunity to pay tribute to her as one of Australia's remarkable older women who made a huge contribution, as many of these people have in Australia. So one of our key challenges as we embark on this journey together is defining older people. And I came across this as while I was putting this presentation together about the definition of old is that when you wake up at the same time that you used to go to bed on a Saturday night. So But the definition of older and old people is pretty much a sliding scale. For some purposes, we would look at it them from above 55, and for many of you in the room, that might make you feel a little uncomfortable and squirmy. Some of our data, the cut points that we use would be either 60 or 65. That wobbles around to some extent. But we're now being much clearer that this is not an undifferentiated population group, that there's people that are considered the young old, so maybe 65 to 75, and the older old, 75 to 85, and now the very old, 85 plus. But I think it's worthwhile thinking about Steve's comments too about Indigenous Australians, that for many Indigenous Australians, that it's important for us to think about the ageing processes starting considerably earlier, and often the cut point there that's suggested is around 40, 45. So it is very much a sliding scale in that regard. But what does the data tell us? The data tells us that we have an unprecedented change in the demographic profile of Australia, as is the case with other developed countries as well. And if you just cast your eye to, I hope it's green, the top green bar at the top there, that between now, 2015, and the next 10 years, we're going to see this significant increase in the proportion of the population who are over 65. And as I stressed, this is an unprecedented growth in the proportion of people over 65. But to really drive home this point, that we will see this increase, so that people over 65 will now represent something like 20% of the population in the next 10 years. So in the next 10 years, so if you think in terms of our services, our programs, the work that we do, 1 in 5 people in the community will be over 65. So now that in itself is an important difference, and it comes with many challenges. And some of those challenges have been highlighted recently in the recent intergenerational report that was produced, which has, leaving aside its own political agenda, one of the things that was stressed in the intergenerational report was not simply the proportion of people who will now be over 65 in coming years, but the proportion of people over 65 relative to younger people. And this is one of the big changes for us. So important to recognise that in the 1970s, where for every person over 65 there was 7.5 people who were much younger. Now what we'll be dealing with is for every person over 65 there'll be something like 2.3 people. Now that's got massive implications for how we operate our community-based services, our treatment programs, and the kind of support that we're going to be able to be giving. So as I say, I'm leaving aside the political agenda associated with this, but for us in the alcohol and drug sector and in the aged care sector, we know that it's been a real battle for talent and bringing in workforces that are appropriate and skilled. Into the future, this will become an even bigger challenge for us because of this part of the demographic change as well. Otherwise, just skip over that part. The other big change that's going to occur is the number of people who will be surviving to 100. And so we'll see a tenfold increase in the number of people who are surviving to over 100 in coming decades. And again, this is a remarkably different demographic profile than what we've ever seen previously before. So massive differences. What we're dealing with at the moment, I'd suggest to you, is probably just the tip of the iceberg. And I love this photograph. It's purported to be the iceberg that sunk the Titanic. And I think it's salutary for us to think about it in these terms. We are able to look at projections and current and emerging trends, and it behoves us to be aware of those changes and the impact that they're going to have on our services, and attempt to respond to them planfully now to avoid some of the disasters that might result. So if I turn now to think more specifically about alcohol and drugs in relation to older people, there's a whole raft, there's an enormous array of alcohol and drug and substances that might be of relevance, but I'm going to focus here specifically only on 4 classes of drugs. Alcohol, tobacco is also quite important for the health and well-being of older people, but we're not going to address it specifically in this presentation. But alcohol, illicits to some extent, and that's becoming a really changing area for us with older people. But certainly prescribed drugs, and it's kind of the key issue to a large extent for older people, and issues about drugs and drug problems and drug interactions. And then the 4th category, for those of you who are not from the alcohol and drug sector, the opioid substitution therapy, or the OST program, pharmacotherapy. that particular client group will change demographically, and it will change in terms of the nature of the people that may be entering pharmacotherapy, partly because of the prescribed drug issues. And so they're the 4 groups that I want to focus on. But it's helpful for us to step back for a moment and think about, well, why is it that older people use drugs? Well, essentially they use drugs for pretty much the same reason that everybody else uses drugs. And it's helpful to think about them as the 3 Ps or the 3 Fs. For pleasure, for pain, or for purposefulness. It's often quite functional the way people use drugs. The pleasure issue is one in the public health area that we really don't like to talk about. That's the primary reason people use psychoactive substances, because it feels good. It doesn't matter whether you're talking about alcohol or ecstasy, it feels good. And people, we like to feel good. So the quest for pleasure and enjoyment is no less diminished as one ages, and you could argue that perhaps it's actually increased and elevated for a number of reasons. We also use drugs for a variety of different drugs to help us cope with pain, and that might be physical or it might be emotional pain. And we, in the alcohol and drug sector, know very well how many of our clients who've got into problems with drugs, it's been a result of emotional pain and emotional trauma from their childhood. Increasingly with older people, we know that there's emerging patterns of problems with people developing, say, an iatrogenic dependence from the use of prescribed drugs, prescribed opioids, from an original organic problem, say back pain or chronic non-cancer pain. But we'll talk about that a little bit more. And drug use is generally quite functional and purposeful, and it may facilitate social interaction. It may simply help you fit into the groups that you belong to. It may serve a whole range of other quite useful purposes in your life. It may be simply that the drugs actually help you to sleep better or improve your appetite. So there's got a huge range of functionality associated with it. So then, if we're thinking then about, okay, what are the issues for us? So the issues in essence are that we've got this changing population profile, a significantly exponential increase in the ageing of the population that's a result of our advances largely in healthcare services, as well as a decrease in our ability to replace our population. And then with that comes this dramatic increase in the number of individuals who will be using alcohol and drugs in a different way and who will inevitably be developing problems. And again, I apologise for the problematisation of it, but this is the reality of it. But also as people age, we think to some extent that there's a decreased incentive to change until their behaviours, until problems become relatively severe, that we can often coast or cruise along, somewhat oblivious to the fact that some of our behaviours around alcohol and drugs may actually be doing us a range of harms. It's also helpful for us to think about the current context and the norms around alcohol and drugs. And here I'm thinking more from a medicalised perspective, that we've very much grown up in an era where there were pretty much pills available to help alleviate any kind of dysphoria or pain or discomfort in our lives. So we pretty much expect, if we have a toothache or a footache, or sort of, we're not feeling blue, that there will be medication that will actually solve that for us. So there's an expectation that we rely on drugs in a way that did not exist for earlier generations. And I say this cautiously, that for some older people, they will have a greater disposable income than previous generations of older people. And I'm careful not to generalise, because that is actually not the case across the board. So if we look specifically at the baby boomers, those who were born between 1946 and 64, I think is the cutoff. So there's kind of this 20-year window that group have used drugs previously at an unprecedented level compared to earlier generations of older people, earlier generations that were moved through their 60s, 70s and 80s. They also hold generally more liberal attitudes about drug use and about alcohol, much more comfortable about it. And the projections from Europe and the United States is that the number of people, older people who are going to be developing problems, is going to double. And between now and 2020. And if we look at the data that I'll present shortly, we're pretty much heading down a similar kind of trajectory. Our other concern is about our clients who go through the NSP, which is the needle and syringe program, for those not from this field, and OST, opioid substitution programs, and bloodborne virus diseases. So many of the treatments for those individuals have improved, and many people have survived and are now living much longer than it was ever expected to be the case previously. So we have clients saying things like, I really didn't think I would be here. So there's a changing face in relation to a range of these sorts of issues for us. In terms of the process as we age, a number of social things and psychosocial things change in our lives in terms of retirement, our change in our lifestyle, our role identifications, that we sometimes might be losing a degree of independence associated with that, and there might be a decline of mobility, the emergence of medical illnesses and so forth. But certainly degrees of social isolation and grief, and so the grief and loss issue is fairly ubiquitous as people age for a variety of different reasons. And that then is associated on your slide on the right-hand side with this range of other factors. So there's also these physical changes occurring, a reduced ability to actually metabolize alcohol and drugs as efficiently as we did previously. As a result of that, there are more complex alcohol and drug-related physical conditions that are going to emerge for older people, combined with multiple morbidities that simply are associated with the aging process, together with multiple medications. So again, it's a common phenomenon as people age. They may be on a variety of different types of medications for pain relief or for hypertension or numerous different conditions. And we're concerned there about complex interactions that also might occur between the use of alcohol and drugs, between age-related cognitive impairment, which we'll be also talking about shortly, and mental health conditions such as depression and anxiety. We know that for a number of different reasons, that older people are also at greater risk of falls and associated injuries. And again, the use of alcohol and drugs can be a significant compounder of those problems, as is the long-term use of opioids. So there's lots of reasons that we need to be focusing very specifically on the different needs of older people in relation to drugs compared to younger generations. And we also it would be remiss of us not to consider also the needs of people from culturally and linguistically diverse backgrounds, Indigenous Australians, as we've flagged, and also older injecting drug users, some special needs amongst those. There's been some previous literature in the field that have identified, and some of Michael Gossip's work previously had talked about, as people age, that in terms of alcohol and drug use, they'd identified people who were considered survivors, that these people had long-term chronic problems with either alcohol or other drugs, and they'd managed to survive into their sort of 60s and beyond, and we're now seeing more of those people surviving for different reasons. There are people that have been described as reactors that never had problems previously with alcohol or drugs, but because of a range of changes in their life, they react by utilising alcohol and drugs to help cope or deal with certain circumstances. But we've added to that typology a group that we would identify as being the maintainers. So these are the people that may have drunk, for instance, alcohol at a relatively low risk, moderate level that was non-problematic by and large in earlier decades and years for them. Drinking at the same level as you go into your 60s, 70s and 80s will become inherently potentially problematic for them. The other one to think about is women. So of that changing demographic profile, there will be substantially more women than men, and women still outliving men, although they're catching up a little bit. But there are some specific unique characteristics for women that we should draw our attention to. They do tend to, we tend to live longer. More of us live alone. Many women lack financial independence or security, often the legacy of poor superannuation. More susceptible to the negative effects of alcohol and drugs, partly because of physiological differences where we've got more body fat relative to body water required to metabolise most drugs. Higher levels of anxiety and depression and some mental health conditions and sleep disorders for which people often get medicated. Greater experience of chronic pain. And often alcohol and drug problems will go undetected because our services in the alcohol and drug field have been for many decades set up to deal with men. To a very large extent, they traditionally grew out of dealing with chronic, severe, end-stage alcoholics in the 50s and 60s, but the ratio of male to female clients has usually been around 3:1 for some decades. But that's a big shift for us. So focusing on what the needs of women are going to be, and I love this cartoon sent to me by a girlfriend some years ago, to stay young, the doctor said to exercise and eat the right foods. She says, what? And I thought he said exercise and buy nice shoes. Sorry, I think I misread that. So. The other big difference for us in the alcohol and drug sector is that many of our services for a long time have been set up appropriately to cater for the needs of young people. mostly young adults, people in their 20s and 30s. The services are not well designed and not well placed to cater for the needs of older people. Huge dramatic shift for us. So let me change gears slightly at this point and have a look at some of the demographic data that's available to us, the epidemiological data that's available to us. And I want to just move through those 4 classes of drugs that I flagged. The first one is that what we know in Australia that's occurred just in relatively recent years, for the population overall, we've seen a decrease in alcohol consumption and risky levels of consumption. So these are National Drug Strategy Household Survey data. This survey is conducted in Australia nationally with a stratified random sample every 3 years. So it's conservative data, it's underestimates, but reliable data. And what you see is that the younger age groups on the left-hand side, we're seeing decreases, statistically significant decreases in risky alcohol consumption. Here we talk about single occasions, so this might be how much you drink at dinner tonight. Drinking more than 5 drinks in a single session is considered to be risky drinking. What you see on the right-hand side are people in their 50s and 60s where they're going in the opposite direction. And I don't think that trend, that pattern has been seen in Australia previously. When we analysed this data and we looked at the difference between the 2001 and 2013 data in this kind of 10-12 year time period. If you look on the left-hand side, this group here, the 60 to 69-year-old age group, that shift from 13 to 16% might not seem much. That's a statistically significant increase in the proportion of 60-year-olds drinking at risky levels. Overall, the population is, on the right-hand side here, the total population is significantly decreasing their level of risky consumption. Hugely important difference in the directions that these trends are occurring. When we look at what's called lifetime pattern, lifetime risk, so here if you're drinking more than 2 drinks in a session and you do that on a regular basis, you'll accumulate lifetime risks. We're seeing the same kind of trend, an upward trend again, and it's statistically significant for older groups. So for us in our field, on both of those measures for us, we're seeing a statistically significant increase, again on the left-hand side amongst the 60-year-olds drinking at riskier levels, and a general decrease in the population overall. I'll skip the data for you there. The other thing about older people is that for the people over 70s are the group that are going to be drinking every day compared to anyone else. And you think, well, is that problematic? Is that harmful? Well, that's an interesting question. We really don't have a good handle on that because we don't have good guidelines about what constitutes safe or low risk consumption. But we do know that, again, if you look to the right-hand side, the 60s and 70-year-olds here certainly got the highest proportion of daily drinkers and relative to any other age group in the community. And that's a concern for us because daily drinking can morph into higher levels of daily drinking, and even moderate levels of daily drinking, if you're also taking other medication, can be a problem. If you've got stability issues, can be a problem. So we're concerned about that area. So we've seen this general increase in risky consumption amongst older groups, a pattern that we've never seen previously before. We're also now seeing, in terms of our services, and again, if you just look at the figures from 2002-03, so we saw, in terms of presentations for alcohol and drug treatment services, we'd be seeing about 2,000 people who were older. But by 2012-13, that number had almost doubled. So as those consumption patterns have been increasing, so too have presentations for specialised alcohol and drug treatment services. And that's what the upward trend looks like. So in the last decade, we've seen a doubling of the number of people coming to alcohol and drug services for treatment. It's also worthwhile thinking in terms of when severe problems occur. So if you think about alcohol-caused hospitalisations, the distribution of this curve here shows concentrations around the mid-age groups, so around the 40s and 50s. Given the emerging patterns of drinking that we've got, we suggest that curve is going to shift to the right, and so you'll see more and more hospital separation, more and more morbidity associated with older people. And similarly, alcohol-related deaths already concentrate in the 50s and 60s group, but again we would suggest that we're going to see more and more deaths related to alcohol occurring amongst older people. So, if I turn to look at illicit drug use, that what we will see here, we're seeing here again is this upward trend, somewhat of a stabilisation in the younger populations overall. If you just remove more localised specific problems about methamphetamine. Most of the issues here around illicit drug use is about cannabis, because that's the most commonly used drug. And what you see for cannabis is this substantial downward trend in people in their 20s and 30s, but a significant upward trend of people in their 50s. So again, these are statistically significant increases in the use of cannabis amongst the 60-year-olds. So again, trends and patterns that we've not seen previously. We don't see huge presentations for treatment yet in our alcohol and drug services for cannabis. I'll just skip over that a bit more quickly. Ignore that little blip in the middle there was missing data. But what you do see is this upward trajectory here in the last couple of years of older people seeking treatment. But the big ticket item for us really is around pharmaceutical drugs. And these might be prescribed and they might be over-the-counter medications for us. But for older people, these are huge issues for us. In the last between say 92 and 2012, we saw a 15-fold increase in the number of PBS-listed opioid dispensed episodes. This is a trend that where Australia is tracking behind the United States, well actually tracking behind Canada first, then the United States. So it's a phenomenon that's occurring in a number of developed countries. Oxycodone was the main contributor to opioid use, and we have also seen a dramatic increase in fentanyl. And that's of concern for a number of reasons. For those of you who aren't particularly familiar with this, this is a bit of a snapshot view for you. So these data show from 1980 to 2006, and the top left-hand corner is oxycodone, so you see an exponential increase in the prescribing of oxycodone in a very short period of time, and similarly fentanyl. Methadone fairly flat, morphine fairly flat. That when we look to a breakdown, so this now goes up to 2008 and broken down by age. The top age groups to whom these drugs are being prescribed are the 80-year-olds, then the 70-year-olds, then the 60-year-olds. We've not seen a concomitant increase in pain that might suggest a need for that degree of increase of prescribing. And these data now go up to 2010, focusing very much on the red line, which is oxycodone. So again, you see this extraordinary increase in the last 10 to 15 years in the level of prescribing around oxycodone. This is a trend that looked like it was tapering, but there's indications that it's increasing, and that we're using stronger medications such as fentanyl, a great concern for us. No good evidence that the use of prescribed opioids are the first line of choice for non-cancer pain, increasing evidence that they're going to cause a raft of harms. In the National Drug Strategy Household Survey, the level of pharmaceutical misuse that people self-report has also been on the increase, as you can see with those upward trends there. And particularly around any pharmaceutical products, but particularly around the painkillers and analgesics, followed by tranquilizers and sleeping tablets. So pharmaceutical misuse is spread very much across the total population, and we see it's high for the 20 to 29-year-olds and 30-year-olds. Sometimes that's in association with illicit drug use, but it's also particularly high, and it's increasing, and those dark bars on the right-hand side of your 50-year age group and your 60-year age groups demonstrate the extent to which misuse, self-reported misuse, is occurring. If we look at things like hospitalisation, and here we've only looked at people over 60, so the blue bar at the top shows hospital separations for poisonings for a range of different opioids. And so that again has escalated in the last number of years, and that continues to increase. And proportionally, we've seen a fourfold increase in hospital presentations for poisonings from this range of opioids here from 89 through to 2011 and 12. So you see this parallel between increased prescribing of opioids and that one measure of adverse events, which is hospital presentations for poisonings. If you just cast your eye across the top three rows there, if you look at length of stay for presentations for poisonings, it's the older age groups, the 80 group, the 70s and the 60s, who had the longest length of stay. Many of the younger people will have had an opioid overdose that may have been related to either heroin or their use of illicits. They're in and out of hospital fairly quickly. Older people, it affects them quite severely, as demonstrated here. The other data that we have available to us, and this has just recently been published, is also tracking the oxycodone-related deaths and oxycodone-defined daily doses. And so what you see is this really close relationship. As dosing and prescribing goes up, another measure of harm is death. And so real concern that's occurring in relation to these drugs in general. The other one that I flagged was fentanyl, one of the stronger opioids available to us. And again, we're seeing upward trends of prescribing, and again reflected particularly amongst older age groups. And we're expecting more severe consequences as a result of these prescribing trends as well. The other piece of data that's emerging more from the United States, where there's some definitive data, but anecdotally from Australia, is that we're seeing a trend in the other direction where people have started out on prescribed opioids, and then that becomes a gateway into the use of heroin for a variety of other reasons. So that merging and morphing between who's an illicit drug user and who's using their opioids because they've been prescribed, that's starting to become very grey area indeed, and it's a huge concern to us. All of this has a great impact on treatment demand for us, and we've already indicated that we've seen close to a doubling of the demand for 50-year-olds, and certainly almost doubling of the demand for treatment for the 60-year-olds in our alcohol and drug specialist services. But if then we turn to the group who are receiving pharmacotherapy, that's the other group that we're particularly concerned about, that if we look at the proportion of those people, and this tends to be a cohort who've been in treatment starting out perhaps on methadone and now on buprenorphine and a number of other substitution therapies, that there's around 47,000 people in Australia who are on the OST program, and about 1 in 5 are now over 50. Now what that means is many of these people will continue on that program. They'll be moving into our community services and our residential facilities, and it's raising real questions about how are these people going to be managed in the community and in various residential or aged care services, as is the question of how are those services going to respond to questions around the use of alcohol and when people are using their level of cannabis and so forth. So substantial increase in the age of our OST clients as well, again as demonstrated here. So another fourfold increase in that area. So in a quick snapshot, what we see are really substantial changes that we've never ever experienced before. The projections and the trajectory are all upward. More older people using drugs, more older people using drugs that are going to cause harms for them. The question for us then is, what do we need? We need better assessment tools. Much of the research we've done in this area, and we're a very evidence-based sector, has never included people over 60 or 65. It's specifically excluded them. So we don't have good tools to work with, and Stephen will talk about the need for screening tools and developments there. We don't have good, clear, definitive indications of what constitutes safe or low risk levels of consumption, whether it be alcohol or other products. And we also are not good about the provision of support or collaboration with the aged care and community services, and that's one of our purposes here today. Nor do we give good, clear advice to older people about what some of these substances might be doing for them. And one of the huge issues that resulted in a very successful law case against Purdue Pharma in the United States was that making it very clear that prescribed opioids have a very large propensity for developing dependence, which had been denied. The manifestation of problems for older people around alcohol and drugs fall into the same kind of categories as for others, that might be problems around intoxication, so some short-term problems that might result in instability and falls and so forth. There might be problems around regular use but not dependence, and there might be problems in relation to dependence. All of these need specific tailored responses. And similarly, we need to think about the potential for issues to emerge along a continuum where someone may be using no substances at all traditionally, but may start to. And this is one of the new things that we're now seeing. People who have not perhaps used any drugs, any illicits or alcohol previously, but start to do so as they age. But there's a continuum, and people may move up and down that continuum, and our services need to be responsive to the various points along the continuum. There's a multitude of potential barriers for people getting support and treatment from us. So some of those for older people might be about shame or embarrassment or discomfort. Some of them is about physical access to the services. Some services actually don't exist in some areas, or as I said, they're not designed to cater for the needs for older people. The attribution of alcohol-related symptoms to just the process of ageing and not recognising the role and contribution that alcohol and drug use is making is hugely important. Some of our services are just outright unsuitable. There may also be collusion amongst family members, and there may be a lack of knowledge about where one could go for help. So there's a range of areas here that we can improve upon. And in terms of professional barriers, there's much that we can do at our own end. There's certainly a lack of awareness about alcohol and drug problems amongst older people, and that's something that we're aiming to change. There's an inability to identify signs and symptoms of alcohol and drug problems amongst older people. Many treatment providers and care providers lack confidence and knowledge and skills in this area. And there's often this reluctance to ask embarrassing, sensitive questions of somebody who's often, substantially older than themselves. And also a belief that perhaps people are too old to change, or that perhaps that we shouldn't be interfering with something that's going to give someone in their later stages of life some degree of pleasure. But what we do know is even making small changes and giving basic pieces of advice can make an enormous difference. So far we've not really got to first base in terms of how we might make these subtle changes before we look at the huge structural changes that are required to help ensure that this growing and expanding valued part of the Australian community will be supported to ensure that they enjoy the best opportunities for health and well-being into their older years. And one of the last things that we'll talk to you about later on today is the development of a MOOC that Alan Triffenoff and I are involved with an international group about how to upskill our workforce in this area. But as you can see, that there are multiple challenges facing us today. Many of them we'll be able to sort of cover in the various presentations that we're going to be addressing throughout the day. But as I emphasised at the outset, what we want is to think in terms of what actions and what strategies that we can put in place to bring about these required changes. Thank you for your time.